been a great honor to be meeting with people here at University of Miami. So I'm just going to tell you a little bit about my own personal research in the area of diabetes in older people, which I've been pursuing for a long time with some sort of timeless questions. So I'm going to talk about diabetes in older adults, but we really use it as a model condition or a condition set for studying patient heterogeneity. And it's actually a model for studying the interactions between one condition and another, which is sort of the bread and butter of what primary care physicians do. But it turns out to be a rich area of clinical inquiry as well as research. I'll review some past research, some of it my own, but also of others about over the last 20 years, how this area of diabetes in older.
One more second.
Yep.
You can't see the screen. Can you share the screen?
If you could see the screen, it's also great.
Okay.
You sure? Okay. Well, then you'll just have to listen to the talk without the slides, which might be actually better. So I'll review the history of the last 20 years of kind of research in diabetes and geriatrics and how this field of geriatric diabetes has really grown. And I'll talk about kind of ongoing questions that we're trying to address in our current research program. I'll talk to you about a project we're doing around social modulation of transitions in diabetes. Is really a project inspired by sociology and social network analysis, which I think is a particularly powerful tool when thinking about how to modify people's behaviors, but also how to modify a whole community's behavior. I'll talk about ongoing research I've been doing for over 10 years with the Kaiser Northern California Division of Research, using their data and also a large survey to understand how people are making decisions about their care as they age, as they become sicker. And I'll end with a description of a randomized controlled trial, My Diabetes, My Community, which is really a culmination of multiple ideas. And it's really a test of earlier, you mentioned the consensus report on diabetes in older adults from 2012 that we published with that was sponsored by the American Diabetes Association. Basically, those recommendations have never been tested in real world clinical practice. And so My Diabetes, My Community is really the first trial that I know of to actually test these ideas around personalization, stratification of care in busy clinical practices. So if you, all of you know that diabetes is really at epidemic levels in the United States and really around the world. What is a little bit less appreciated is that really diabetes is a disease of older age. It's a disease of older adults. And you can sort of see this from this prevalence figure, this older prevalence figure from 1999 to 2002, which shows the prevalence of undiagnosed and diagnosed diabetes just by age. And just a quick, just to remember, basically a quarter of older adults, people over the age of 65, have some form of diabetes, the majority of it being type 2 diabetes. And another way to flip around and look at it is, if you look at the population of people with diabetes in the world, about half of it is made up of people over the age of 60. So diabetes in older adults is really, it's really the predominant, it makes it the majority of people who have diabetes. And that is not always appreciated, because if you follow, the American Diabetes Association or Juvenile Diabetes Research Foundation, we sort of think of childhood type 1 diabetes as sort of the paradigmatic version of diabetes. It's actually how they raise money. We don't bring out older people with diabetes, but this is really the majority problem for really the United States, but also the rest of the world. And it's a direct problem for policymakers as well, because all the costs of diabetes care among older adults is basically borne by the state, in particular the federal program Medicare. If you know the history of U.S. healthcare policy, we've somehow designed a system around the edges of the population. So we've guaranteed insurance for people over 65 first. We guaranteed insurance for people who are poor, and then only through the Affordable Care Act have we sort of filled in the gaps with insurance. So by just the historical nature of healthcare policy in the United States, we guaranteed that we would be bearing the cost of diabetes care for older people in the United States since 1965. This is a forecasting study that we did over now 10 years ago, which was used simulation modeling and population modeling to project the growth in the population of people with diabetes over time, but also the associated spending with different birth cohorts. And you can sort of see that the red group here, this red band of expanding costs, really represent the baby boomer generation, and they're already hitting the Medicare program. And then, but overall, from 2009 to 2034, we projected that the cost of diabetes care would triple. Now, this forecast was already scary at the time, but this actually preceded what happened in the last 10 years, which is that drug manufacturers have at least tripled the price of major drugs like insulin analogs, even though the product is actually unchanged over that time period. So politically and policy-wise, we've been really engaged with actively around trying to control the cost of insulin itself, which is which is necessary for people with type 1 diabetes and fairly important for people with type 2 diabetes. So big public health problem just in terms of populations, cost of care, and rising cost of care. So when you talk about diabetes in older adults, you have to talk about the co-occurring conditions or complications of the disease. And like many other conditions of chronic diseases of older adults, there's a high prevalence of other conditions. And this graphic just shows you it's a cross-tabulation of the coexistence of other conditions, such as coronary artery disease, heart failure, but other geriatric important conditions such as falls, urinary incontinence. And you can see the majority of people have at least one other condition when they have diabetes, but a quarter have at least two. And these numbers are likely underestimates of the level of co-occurring diseases among older people with diabetes. So when we talk about diabetes in older adults, we're really talking about how do we handle or how do we deal with the co-occurring diseases? So the questions that have been behind our research program really have not changed because we, over the last 20-something odd years, because in some ways the evidence has changed, but we still have challenges in answering these questions. So the questions are, how do we best treat the individual older patient with diabetes? How intensively should we control glucose?
Sorry, can you just share put
Sure.
the share screen on so they can see the screen direct? They'll
Okay.
miss you, but they'll see the screen.
Okay. All right. Yeah. Great. Okay, so I was just retelling you about the three kind of central questions which are behind our research. How do we treat the individual older patient with diabetes? And this is really a question of how do you translate evidence that's generated from clinical trials, and how do you take that data and translate into the actual care plan for an individual? It's kind of a central question for multiple areas of medicine, but we use diabetes as the condition of interest. How in the area of diabetes, there's kind of this ongoing question about how intensively glucose should be controlled, how low should we go, and then what medication should we use for the individual patient that we're seeing? So pretty basic questions, and I'll try to show you how they remain controversial and a little bit uncertain to this day. So the first question about translating information from clinical trials to the person we're seeing is particularly salient for the care of older people with diabetes. Not so much people in their 60s anymore, but really people who are octogenarians over 75, and of course, the very sick. And this is just a graphic from the New York Times showing this kind of basic problem we have with evidence-based generation, which is that typically in science, we start with the simplest model that we can that doesn't have any confounding at all. And we do that experiment to prove a point. And in human clinical trials, and it's kind of cruel to talk about people as a kind of, as research subjects, but we do the same thing with humans. We basically do trials in the human version of the disease that is simplest to understand and is not affected by confounding and is not going to mitigate the signal of what we're trying to find. And so this graphic just shows, from New York Times, shows that older people historically have been left out of randomized controlled trials because they are just too complicated. And there's any outcome you see in a randomized controlled trial is going to be complicated by comorbidity, other events at higher rates of adverse drug events. So here's the brief history of glycemic control trials in the area of type 2 diabetes. So it is kind of amazing, but in my lifetime, some of the major and I don't think I'm that old, major randomized controlled trials in type 2 diabetes management have come out as I've been in training. So this is an example of when I was a resident. So when I was a medical student, I think the DCT trial came out. So the first evidence in 1993 came out that glucose lowering was beneficial in type 1 diabetes. It's not until 1998 that we have the publication of the United Kingdom Prospective Diabetes Study, which basically was the first trial to show that glucose lowering was beneficial for type 2 diabetes. So it's not until 1998, I'm a resident at that time. It just comes out at that time. Before that, doctors and endocrinologists and diabetologists had been managing it with the hypothesis that glucose lowering was beneficial, but this was the first trial to show that it did. And what it showed also was that there's a timing effect with glucose lowering. So these are all the people enrolled in this trial had new onset diabetes. They excluded people over the age of 65. And this trial is actually went on for at least 10 to 15 years. And then they have actually been able to follow the patients up to 30 to 40 years. Very recently at the recent EASD meetings, they presented 40-year follow-up on these patients. So this is, what happens to a patient who achieves intensive glucose control in the first 10 years of their diabetes. And on the left side of this figure, you can see that during the course of the trial, patients had to live 9 years before there was any separation of event curves. And the events were basically microvascular events, progression of kidney disease, early eye disease, and neuropathy. But at that point, then the cumulative event curves separate. So it takes 9 years at the start of diabetes management to see any benefit of intensive glucose lowering. On the right graphic, you see the legacy effect that we've now learned from DCT and from UKPDS that happens when you are treated intensively earlier in your disease course. And the recent results I showed you, I referred to, now show that actually the legacy effect lasts for up to 30 to 40 years. So it's kind of amazing. After the initial point of the trial, patients were allowed to actually converge and have similar glucose levels after the 10-year mark, but there's still a legacy effect of that early glucose control. So remember that you need to live at least 9 years to see the benefit of that early control. So then after UKPDS was published, and probably around the same time, there was criticism of the UKPDS because it actually, during the course of the trial, it did not show that you could prevent cardiovascular events with glucose lowering. And so a series of trials were designed in the early 2000s, the Accord from the NIH, Advance from Europe, and then the VAT done in the VA, all asking the question, if we lower sugar even more to an A1Cs below 7 to 6.5, can we prevent cardiovascular events? And again, remember UKPDS and in these trials, they're all using the medications available at the time, not the medications we have now. But what's amazing is that these trials had such rigorous protocols, they were actually able to achieve separation of A1C curves. And of course, what happened was the Accord trial actually ended up having a higher mortality rate in the intensively treated arm and the trial had to be stopped early by the NIH. So this was a completely surprising result that has confounded people to this day to figure out what happened. All we know is that the people in the very intensively treated arm died at a higher rate. VADT and advanced did not have that same mortality outcome. And it's an overall observation from these randomized controlled trials is that you can prevent non-fatal MI with some intensive glucose lowering, but not much else, and at great expense in terms of the medications that were used at the time. Now, the other thing I would say is that, remember I said the UKPDS excluded people over the age of 65. These trials were the first trials to enroll people in their 60s. And you'll notice that they all have a duration of diabetes around 10 years. So they're meeting patients about 10 years later than they were in UKPDS, and they're older. So these trials accidentally became the first geriatric diabetes trials of glucose lowering. Okay, so of course we live in 2022 now, and there's been a decade's worth of basically drugs that were inspired in some ways by, I didn't mention rosiglitazone, but there was a controversial trial related to rosiglitazone, which had cardiovascular risks associated with it. The FDA changed regulations and then required all drug manufacturers to start doing cardiovascular outcome trials, safety trials, to ensure that diabetes drugs did not induce cardiovascular events. That accident in policy actually has now led to this proliferation of trials showing, comparing drugs, new drugs to placebo. And they produce basically surprising results that we now know, that we now use in clinical practice, such as the beneficial effects of SGLT2 inhibitors. In this case, it's empagliflozin, showing improvements in death from cardiovascular causes, death from any cause, and hospitalization for heart failure. And the same is true for the new GLP-1 agonists. So in terms of trials and generalizability to the patients that we see in front of us in the real world, basically before 2010, UKPDS excluded people over the age of 65. And actually, if we had applied UKPDS, it would have excluded most of the people, over half of the people with new onset diabetes. And the trials of Accord Advanced VADT still had actually major exclusions of most older people with diabetes. But after 2010, the evidence base has actually improved, that we now have more direct evidence for from these drug placebo trials that have included patients in their 60s and 70s, but they all had elevated cardiovascular risk. And some of these trials still have exclusion criteria that are important for the patients that we see in front of us. So for example, the SGLT2 trials have generally excluded people with eGFRs below 30, history of cancer, history of severe hypoglycemia. They still don't want people with a lot of the side effects that would be expected from diabetes medications. The recently published GRADE trial also excluded people with creatinine over 1.4, active ischemic heart disease, congestive heart failure, so you can sort of see that there's, and actually they excluded people with diabetes over 10 years of duration. So there are still important leaps of, basically we have to make translational leaps in our heads when we're taking care of a patient. Would this patient have been qualified for the randomized controlled trial? What's different about this patient we're seeing? And how do we modify the care that we deliver? So I'm going to talk about, so I've talked a lot about the trials, but now let's talk about the real world and the real world populations that we take care of. So I mentioned earlier that if you did a cross tabulation of diabetes with other chronic diseases, you get a lot of crosstalk. There's a lot of co-occurrence of these conditions. And so one of the challenges, how do we deal with that information about the other diseases? Do we just think about each condition one at a time, or is there some way that we can logically approach comorbidity, basically? And there's a lot of different ways of doing it, but I want to show you one way that we've approached comorbidity and classification of patients. So this is actually using a statistical technique called latent class analysis. It's actually used, we actually do this, sociologists use this all the time. And actually there have been some pretty well-known, there's a recent latent class analysis done with genetic information and other biomarkers, but this is just using the chronic conditions of a bunch of patients from a nationally representative study, the National Social Life, Health, and Aging Project. And we let basically the machine tell us what are the naturally occurring clusters. And when we do this, we get 3 clusters. This is a paper from over 10 years ago, led by one of my mentees, but now mid-career faculty, Nita Tirapong, we find that there's actually three major classes if we sort people by comorbid conditions. Class 1 represents about 50% of the population of older people with diabetes. They tend to be relatively healthy and have very few chronic conditions. And on the x-axis is basically the number of conditions that people have. And it's just a simple histogram of how many conditions people have. So you'll notice that class 1 tends to have less than 5 co-occurring conditions. Class 2 and 3, though, had a much higher number of chronic conditions, and they're interestingly kind of distinctive. Class 3 tends to have a lot of cardiovascular disease, heart failure, stroke, and coronary artery disease. Class 2 tends to have a lot of geriatric conditions in urinary incontinence, falls, frailty. And we've actually, I'll show you actually later on that we've sort of been able to replicate this in other versions of newer waves of NSHAP, but also in other data sets. So it seems to be something that we can actually replicate and find these three clusters. Remember the number 3. So the other thing that we can do with real world data is understand the natural history of diabetes. So this is data that comes from a paper using data from the Kaiser Diabetes Registry out of Northern California. And it turned out that no one had actually updated our understanding of the natural history of diabetes for over like 20 years. So we used more contemporary data from Kaiser to basically just characterize the event rates, what happens to people as they age, what happens when they have different durations of diabetes. This is an extremely blissfully simple study, but important because it provides the baseline of, what are we trying to prevent? What's happening to people, and how can this guide our treatment? And I just want to point out a couple of things in this table, which is that you'll notice that the octogenarians have very high rate of mortality, of course, compared to people in their 60s and 70s. But notice the difference between acute hypoglycemia and the cardiovascular event rates. Compare the hypoglycemia rate to the rate of DKA, end-stage renal disease, and eye disease. So what's important to note from this from this table is that hypoglycemia is extremely common. Being an octogenarian itself, it accelerates your risk of having a hypoglycemia. And hypoglycemia actually has the same event rate as cardiovascular disease in this population. And basically the microvascular events don't happen. So this kind of this natural history study sort of helps us to understand how important hypoglycemia is, especially as people get into extreme, very late older age. This is another graphic from a different kind of data set. This is data coming from Medicare and Medicaid claims. This is from Medicare claims. So this, real world data can come from health systems. Real world data can come from insurance claims. And I'm in some ways demonstrating to you the power of these different data sets. This is a trend analysis showing the rates of hospitalizations for hypoglycemia, which are in blue, and hyperglycemia in yellow for the whole country's Medicare beneficiaries. So that's the other thing about Medicare or Medicaid claims is that sometimes you can study a whole state, you can study a whole country. In this case, this paper was very powerful because it showed that acute hypoglycemia hospitalizations around 2000 became more common than hospitalizations for acute hyperglycemia. Basically, the side effect complication of diabetes became more prominent than the actual thing we originally tried to prevent around 2000. Now, these curves are shifting and changing over time, and there actually are some newer studies extending this data out over the last decade. But again, this brings home the point that hypoglycemia is particularly important for the Medicare population, more so than DKA or acute hyperglycemia. Okay, so the other value of real world data is, of course, to re-examine the epidemiology, especially for older people and sicker people, is to re-examine the epidemiology of the disease. In this case, what we've done is we've looked at the relationship between A1C and mortality. And this paper came out around the time the Accord trial came out and has been actually replicated multiple times across observational studies. So again, this is an observational study looking at baseline A1C and mortality. And we found that basically there's a U-shaped relationship between A1C and death, that there's actually a flat point between basically A1C of 7 to 7.9 or 6 to 7.9, where you actually have the lowest rates of observed mortality, but there's a higher risk of death at very low A1Cs and a higher risk of death at high A1Cs. And this has actually led some people to extrapolate this into actual care guidelines, where some care guidelines actually recommend a landing pad for glycemic control. Others, including the ones I have participated in, do not actually have a landing pad on the lower end of A1C. But in any case, this epidemiologic finding by itself is interesting. The explanations are likely a little bit complicated. It could be that low A1C is a signal, or just happens to be a epiphenomenon of pending mortality for a person. Okay, and then another tool I want to highlight is simulation modeling. I mentioned that earlier. We've done simulation modeling to forecast the fate of the whole country's diabetes population. But for a given individual, we now have at least 20 to 30 years of history of doing research using simulation models. These simulation models are based on basic epidemiologic models, but then are stitched together to forecast the entire life of a person with diabetes. This is just a schematic of a typical type 2 diabetes model, which shows that there are modules for eye disease, kidney disease, neuropathy, coronary heart disease, and stroke. Each year, a hypothetical patient is cycled through the model, and they're at risk for death, of course. And there's some very well-known models now that, and we have actually been building brand new models that reflect the multi-ethnicity of the United States. Most models right now are actually, funny enough, based on UKPDS data, which is 95% English white from the 1970s and 80s. So we are trying to update these models to reflect changing diversity, but also changing natural history of disease as people are treated differently over time. So just to give you an example of how we've been able, this is an example of taking data from a clinical trial and then extrapolating it using a simulation model to answer a question for the given patient in front of you. This is results from a simulated in silico trial where we said, if we could do the UKPDS 1,000 times and change the health status of the patient and do the same trial in a nursing home, for example, what would happen? So in this model, what we do is we alter the baseline risk of death, which we know we can predict based on comorbidity and functional status. And you can see as the patient's level of comorbidity and functional impairment rise, the expected benefits of intensive glucose control that we achieved in UKPDS steeply decline, such that basically what a person with 5 conditions or 6 conditions or 5 or 6 combinations of comorbid illnesses or functional impairments already has a very low likelihood of benefiting from intensive glucose control, going from an A1C of 7.9 to 7. So that combination of clinical trial data, but also mixed with our observations from real world data and also our use of in silico trials, is influenced the first consensus statement about diabetes management for older adults from the American Diabetes Association. As mentioned earlier, I helped to write and basically codify some of these ideas into these care guidelines that are roughly this, and I've edited the guidelines over the last 3 years. They basically maintained this kind of 3 strata system. Remember, I highlighted that we found if you classify patients by comorbidities, there are basically 3 classes. And multiple organizations such as the VA, the American Geriatric Society, and European Diabetes Group have all adopted a 2-tier or 3-tier system. There's no active collusion across these groups, and they kind of independently arrived at these recommendations based on the evidence that we saw. But you'll notice that there are major important differences in the guidelines. The ADA, which I helped to write, basically says there is no lower limit to control. That, if a patient is doing well, has a low A1C on multiple medications and is tolerating it, we allow them to be as they are. But the American Geriatric Society has this very narrow landing pad where the patient's A1C has to land within this narrow 0.5% range. And the Endocrine Society recently has also come out with guidelines with landing pads, but only if you're on specific high-risk medications such as insulin and sulfonylureas. Otherwise, there is no landing pad. So the diversity in these guidelines basically tells you that there is still considerable uncertainty around how to manage the older person with diabetes. The basic concepts, and there are multiple concepts at play here. The big one, of course, is this idea of the lag time to benefit versus life expectancy of the patient. And this is applied to other areas of preventive medicine as well. Basically, the idea is we should not do something if the patient is not likely to benefit from it. So, for example, in the case of mammography or colonoscopy screening, colon cancer screening, typically a person has to live 10 years in order to benefit from that screening. So that's why you'll notice that U.S. Preventive Services Task Force guidelines typically have upper age thresholds of like 75 or 80 as a rough estimate of life expectancy. And similarly in diabetes management, you'll notice that we have this sort of multi-tiered system. This is essentially based on time to benefit. So the healthier patients, healthier older patients that are likely to live at least 10 years, we recommend pursuing the same goal as a middle-aged patient or younger. But the more complicated the patient becomes, basically the shorter the life expectancy, we allow more leniency in terms of the glucose target so that there's more freedom for the doctor to and the patient to choose goals beneath that. Other concepts include relative benefit versus risk of therapy. This is something that we could try to quantify, but we typically do it in a kind of qualitative way with patients. There are actually sometimes specific comorbidity therapy interactions, especially with many of the newer drugs we have. A specific condition triggers the need to use a medication. And a big one in diabetes for older people is this whole idea about their ability to adhere to the therapy. We should not be prescribing something that a patient is unable to deliver. And frequently with older people, we have to consider the social network around them. So I want to move briefly to kind of ongoing projects that I want to feature. These are all related to diabetes in older adults, and just for fun, show you some new findings. Some of them are not yet published yet. So in the area I mentioned earlier that I've developed this collaboration with sociologists at University of Chicago, the idea behind this project is that we know some of the major risk factors for developing diabetes, such as body mass index, race, ethnicity, and so on. But is there some possibility that the social world of the person puts them at greater risk for developing diabetes or having maybe even remission of diabetes or remission of pre-diabetes? And this could be through social networks, social support, addressing things like social isolation and loneliness. So we have actually done this work using both the National Social Life, Health, and Aging Project, but also the Health and Retirement Study. This is an analysis showing the association between different social characteristics and the risk of going from no diabetes to diabetes over the 4 to 5 year period. And you'll notice most of the social factors actually hover around 0, so they're actually non-significant, but a couple stand out. One is, where is loneliness? So loneliness emerges as a major factor for developing diabetes. So the more lonely you are, the higher your risk of developing diabetes. Another factor that I don't know may resonate with some of you is having a kind of a negative spouse also increases your risk of developing diabetes. So those two come out. There are some differences between the studies in terms of the number of friends you have in your network. There's some signal from NSHAP that the more friends you have, if you have no friends, you have this very high risk of developing diabetes. But we did not find that in the Health and Retirement Study. So you just think about your own social life and how you can sort of make up a story of how someone might develop diabetes because of these social differences. And then we've also used the same data sets to re-examine this heterogeneity question. And we've, again, used sort of this latent class analysis, but again, applied to different data sets to say, are the 3 clusters we found over 10 years ago still present today? Again, I showed you this earlier. I didn't mention that class 1, the healthy class, has a death rate of 9%, a 5-year death rate of 9%. Class 2 has a 17% death rate, 5 years, and class 3 has the highest death rate. So we repeated this analysis in the NSHAP 2010 to 11, and you're not meant to look at the numbers, but look at the colors. You'll notice that the pattern of colors is basically identical from the first wave and the second wave, which means that we refound the same 3 classes. And you'll notice that class 3, again, has this really high rate of cardiovascular disease. Class 2 tends to have a little more incontinence and other kind of geriatric issues. They're more obese. And class 1 remains the healthiest. So we basically recapitulated this latent class analysis finding. And we found that class 1 and 2 and 3 have different associations with other geriatric concepts, such as frailty and disability. So class 2 tends to have a higher relationship with frailty, which is measured in this study by gait speed. And class 2 has more association with disability as well. And class 3 has the highest association with death. So class 2, that kind of more geriatric group seems to be more disabled and more frail than the cardiovascular group, which seems to be a group just ready to die, unfortunately, from their cardiovascular disease. So these sort of, I don't know if these ring true for you from your clinical practice, but I see these people. You sort of, as you're taking care of people, you're like, wow, that's actually a class 2 person or a class 3 person. So this was the kind of the biggest leap we did, which is we went from the data sets of like 10,000 people from NSHAP, 2,000 or 3,000 from NSHAP, and applied it to this giant registry of Kaiser and looked for the same groups. And this middle group is actually this is just re-showing the heat map from NSHAP. And you'll notice that the heat map is basically, when we apply to Kaiser, we find the same heat map. We seem to find the same 3 classes. Again, high rates of cardiovascular disease in class 3, lots of obesity and geriatric conditions in class 2, and a relatively healthy class 1. So we think that we have, the same conditions are used. We suspect that these patterns are repeatable. And what we did was we were able to extend that original observation about the classes to start looking at their natural history of disease. And you'll notice that these are basically different complications of class 1, 2, and 3, and and there seems to be basically a stepwise elevation of risk going from class 1 to 2 to 3 for basically all the complications. So class 3 is really interesting because it's basically the group that is eligible for SGLT2 and GLP-1 inhibitors, agonists. They're a very interesting group because they're at the highest risk of dying. They have the highest risk of cardiovascular disease, but they also have the highest risk of hypoglycemia. They basically have the risks of both the adverse events as well as they're basically at the point where they're about to experience the complications of the end-stage cardiovascular complications of diabetes. And so that's a very difficult group to manage and treat and think about because basically this study has revealed that you can basically have these things in combination. High risk for adverse drug events, high risk for actually complications of the disease, and so on. So I want to talk to you at the end now for the last for just a few more minutes. Talk to you about a randomized controlled trial that we have underway, which is trying to implement the guidelines we wrote 10 years ago. This is some of the members of the team that are involved in this randomized controlled trial. My co-partner is Stacey Lindau, an obstetrician gynecologist who is the founder of a product I'm going to show you. It's kind of the Google of community resources called Community RX. And you'll notice that I'm the only male in this entire research team. The randomized controlled trial was funded in the middle of the pandemic. There was a special RFA for large-scale trials addressing health disparities, and we had been trying for for anybody who are younger who've struggled with grants. I think I may have tried like 8 different versions of this randomized controlled trial idea, and this one finally was the one that got funded. And it's a 3-arm randomized controlled trial with an attention control arm, a group that receives something called My Diabetes Goal, which I'll show you in some detail, where people go through a goal-setting exercise. They're actually sorted into the 3 buckets of the American Diabetes Association guidelines, and then a nurse helps them to achieve whatever goal they set at the beginning of the trial. My Diabetes Goal plus Community RX, the patients receive the nurse calls, but also receive additional community resources through the community resource referral system. So the purpose, the real distinction of this trial from other protocols is the formal structured approach to goal setting for A1C. We use basically a mortality prediction model as well as a hypoglycemia prediction model, and use shared decision making to arrive at a goal for the patient at the start of the trial. So unlike most diabetes trial where there's a single goal for a whole population, each patient has a distinctive goal based on these sort of geriatric principles. But once a goal is selected, we are like any other randomized control, any other kind of diabetes quality improvement or care improvement effort, we try to get the person to that goal by affecting their monitoring their adherence, dietary knowledge, physical activity, addressing comorbidities, and then trying to address social and economic barriers, especially with community RX. So these are some of the components of this is actually the fancy protocol that our nurses receive when they're in training to do the My Diabetes Goal section of the trial. And you'll see at the bottom is this sort of tricky part where we actually have the patients go through a life expectancy prediction model, but we don't actually talk about it. We sort of say the American Diabetes Association recommends this, and they can ignore us or they listen to us. That's what we don't know actually how this will because the trial is still ongoing. We don't know how people will respond to this, but this is what's distinctive about our randomized controlled trial. Then the community RX part, this again additional supports for getting patients to change their self-care behavior is basically done through this community RX and where it's introduced at the beginning by one of the nurses. The community RX looks like this. It's not a great picture, but basically patients get resource referrals based on their zip code and depending on what they're looking for. If they're looking for help with food, exercise, diabetes supplies, this localizes the resources to where they live. And you'll note that NowPow is actually now it's actually in multiple health systems around the country. And it's actually recently been bought by a company called Unitas. And the contention control arm actually has gotten a lot of, we actually spent a lot of time developing this to follow best practices for conducting intention control trials, where we sort of talk about something relevant to the older person, but it's not directly related to diabetes. And we actually have this fairly sophisticated informatics background where NowPow, the community resource referral system, is directly connected to REDCap, the survey tool that many of us use, and also connected to this text messaging company system called Mozio. So patients actually get their surveys via text. They get reminders about calls via text, and they get, so this system is supported this and other randomized controlled trials that I do with Stacey Lindau. And all of this also happened, I actually had to do some administrative stuff before doing this because it was difficult to do randomized controlled trials at the University of Chicago. I'd say 10 years ago. We didn't have actually that many clinical practices. So 3 or 4 years ago, I helped build the University of Chicago's practice-based research network, which basically allows us for planning for future randomized controlled trials and other studies in advance of even the submission of grants. And this helps us to engage clinical practices, but also to avoid research contamination. I can tell you, when I was a fellow at Harvard, there were 4 diabetes randomized controlled trials going on in the partner system at the same time that were contaminating each other because they did not have a PBRN. So thank you. I hope that stimulates some ideas.
Wow, Elbert, that was absolutely stupendous. Thank you so much for coming. No, don't go away, don't go away. Especially during the threat of a hurricane, and you still came. And I'm just so proud of all the things that you've done and accomplished. That's absolutely amazing. There are a couple of questions on the chat, but let me first ask one of my own. So when we think about stratifying risks and so forth for diabetes in the elderly population, how does one do the calculus whether they're 80 and they've had diabetes for only 3 years, or they're 80 and they had diabetes for 15 or 20 years? You think it might be, obviously, maybe it's borne out in the other comorbidities. And the other part of that corollary to that, is there a different definition for diabetes in an octogenarian than there is based on physiology, than there is in a younger person?
Those are both, those are really good, spot on questions. The first one about in octogenarian with basically new diabetes or established diabetes, I think you're absolutely right. The current guideline is pretty crude. It doesn't account for that. And actually, that's one of our new project ideas is to think about doing a specific study around people over 75 with new diabetes, which we believe actually a ton of research with all the CVOT trials has gone to basically people with long-standing diabetes. So they're over 65 and they have complications of diabetes, but they all have diabetes of 10 or more. We basically need to do the octogenarians UKPDS using modern diabetes drugs to basically answer some of your questions. Apart from that, I mean, if the person's the question is the physiologic age of the person. So not octogenarian can have new diabetes and be relatively healthy and could live into their 90s. So we can account for that with comorbidity, not with great precision, but I think that's the way to think about that person. Your second question was about, can you say that again?
Definition.
Oh, that is actually an open, active question. There's actually active questions about defining diabetes, but also should we be using different outcome measures for older people with diabetes? So that's absolutely an open question. A1C's pretty unpopular among many geriatric endocrinologists because they think it may be inaccurate. It doesn't, 75% of older people have some form of dysglycemia. That can't be a disease, right? If 75% of the population has something that's off, maybe that's just part of normal aging.
That's what we say about obesity. And in that line, Dr. Wolf on the chat asked, what do you recommend? Dr. Wolf in the chat recommended, what do you recommend for weight loss as a corollary in treatment for elderly diabetics?
Good question also.
Wait, do I need this?
You don't need it.
I mean, I'm sure some of you may be thinking about, medications and so on, which are really on top of mind right now, like tirzepatide. But for older people, I mean, I love the look ahead. Honestly, I love the protocol of the look ahead trial, which you may or may not know about. But the look ahead was basically a modified version of the diabetes prevention program, and was, in my mind, it was considered a failure because it was ended. It did not prevent its primary outcome, but people came off medications with better diet, exercise. So I think the look ahead protocol that you can address weight loss with lifestyle in older people and actually be quite successful.
Thank you. Dr. Punjabi, you want to ask your question?
So thank you very much. It was a great talk. A lot of interest in diabetes on this campus. You did some latent class analysis and you showed there are 3 classes. The question is, do the individual components of each class, when you add them together, is there an additive effect? Is it a simple additive effect? Or is it an interactive effect if you look at potential outcomes? So for example, in your cluster 2, I believe, in the middle, there's a lot of comorbidities. Well, when you add in the attributable risk to whatever you're looking at, let's say if it's mortality or CVD, if you just add the components, do the components themselves add enough to the extra risk? Or is it an augmented risk above and beyond that? The second part of that question is then you showed the heat map matrix of your classes and then comorbidities. Isn't that a vicious circle because you use the comorbidities to derive the latent classes?
Yeah, no, the
Great
latter.
happy talk, by the way.
Yeah, no, the latter point is a criticism we get from reviewers. There is some circularity, we do the best to separate, what we know are baseline prevalent events versus new events. But that, and also you'll notice that if you think about what happens to people, this is a study I would love to do, is actually to in a shorter timeline, watch people as they evolve over time and accumulate these conditions over time. I think that would be really informative. It's basically a fundamental study of kind of aging and accelerated aging that we see in diabetes. But your first point is actually, I think we actually did that analysis where we put in the original variables and the classes. And I believe the classes have an independent effect out above and beyond the individual conditions.
So Dr. Huang, I want to thank you again for a superb grand rounds. I want to thank Darian for orchestrating the first in 2.5 years, in-person grand rounds with food and audio visual. Although we had some lumps and bumps at the beginning, I think we finally got it down. Thank you very much. Thank you all for coming during the weather. Do not forget to get your CME credit by either clicking the link in the chat or scanning the Rorschach sign on the outside of the lecture hall. Thank you all for coming and have a safe day.